Good morning, everyone. There is a note in the meeting chat asking participants or attendees to please go ahead and add your name and your position and or agency that you are with. That would be great for our meeting minutes. Thank you.
This is Michael Spindler, LCSW. I am with Never Give Up Youth Healing Center. I am a consultant and clinical lead.
Good morning, everyone.
Good morning.
Good morning.
Chair Schrag, it looks like we have quorum.
Fantastic. All right. Well, then we'll call this meeting to order. And if we could have roll call, then we'll get started.
I can do that. Can you hear me okay?
I can, yes.
Okay, great. So let me get started. Arvin, Operario.
Present.
Braden, Schrag.
Present.
Daniel, Ficalora. Gregory, Giron.
I'm present.
Jasmin, Cooper.
I'm present.
Lisa, Durette. Lisa, Ruiz, Lee.
Present.
And Nathasa, Mosby. Okay, we have quorum.
Excellent. Then we'll get started. Well, good morning, everyone. Thank you all for being here today. We've got a pretty specified agenda. We'll get through some of the main items first, and then we'll go to why we're here today. So we'll start with public comment and taken on a matter raised under this item in the agenda until it has been placed on an official agenda. And as a reminder, all public comments are limited to 2 minutes and 2 minutes only. Do we have anyone with public comment this morning?
Me, Kehalani McCullough.
All right. All right. Go ahead.
Oh, I'm one of many recent former employees of NGU. If I had to describe NGU in a few words, it would be deceptive, unorganized, ill-prepared, and unsafe. To give you an idea of the perceptions of upper management, I will quote the current trainer: "The longer we keep the children here, the more money we get." To give you insight of what the training's like, I'll quote management on my first day on campus. "What training? Children are living in the most restrictive environment with 13 to 15 hours a day spent in the classroom. They eat, breathe, sleep classroom. Gym, field, and hygiene are luxuries not always afforded to them. They do not receive the proper medical care when needed. Only when parents called CPS did they take a particular child to get checked. Turned out her toe was fractured from a restraint. Medical restraints are used as threats to gain control over situations, no matter how small. Physical restraints have been excessive and sickening. Staff have punched, choked, tripped, twisted wrists, dug fingernails into children, just to name a few. Staff have offered items for sexual favors and have been rumored to have sexually assaulted children. Staff have name-called and ridiculed children. Kitchen staff have attempted to consciously feed the children rotten food, as well as NGU has withheld food as punishment. It is not a question of if these things are occurring, it's a question of what time every day are these unlawful acts taking place. NGU does not self-report every restraint, nor does the nurse check every child after being restrained. You cannot trust restraints are being done correctly when staff actively speak on how to get away with abuse. You cannot trust the reports because they have been known to alter or write reports even if they weren't there. The night report is riddled with negative feedback, everything to make the child appear ill-behaved and NGU appear to be needed. You want proof? That's easy. It's reflected in the child's behaviors and mental attitudes as they are a reflection of their environment. While we sit around debating if these things are occurring, which they are, there are actual lives at stake. I close out with a call to action. I ask all necessary departments to assist these children. Their safety and well-being are in your hands. I also call for the resignation and separation of the following: Diana Wade, Benjamin Osteen, Mark Jackson, Risa Tiata, Riley Tiata, Tyler Kaufman, Nikki Hanks, Sarah Espinoza, Tammy Cox, and Matt Cox, and any other employees who have broken contract and law requiring them to report suspected abuse and neglect. You have prolonged the torment and torture of countless children for too long. And that is my statement.
Is there anybody? Thank you, ma'am. Is there anybody else with public comment? I see. Carrisa.
Yes, good morning, Commissioners. My name is Carrisa Tashiro, Carrisa Tashiro, and I'm an attorney with Nevada Disability Advocacy and Law Center. We're the state's protection advocacy agency, and by federal law, we're responsible for accessing facilities serving individuals with disabilities to monitor and investigate allegations of abuse and neglect. We appreciate you convening this meeting to discuss the use of restraint and seclusion at Never Give Up. We share serious concerns about the use of these practices at this facility. This year, we've received over 650 serious incident reports from Never Give Up, and most involve the use of physical restraint. We've also visited the facility multiple times since May 2nd, and each time we hear stories from nearly every youth we've spoken to about how they've been restrained, often in inappropriate circumstances and using unsafe and painful techniques. In June, we filed a complaint with the Bureau of Healthcare Quality and Compliance about the use of restraint and seclusion at NGU, as well as abuse, dangerous conditions, and inadequate access to behavioral and medical treatment. HCQC largely substantiated our complaint, but we believe the corrective action plan that was implemented falls short of what is necessary to protect the youth at that facility. For example, HCQC found that NGU could not show that some of its employees were restraint trained, that some were supposed to complete self-directed restraint training, that there was no written policy on restraint technique. Yet the corrective action is for NGU to print training certificates for its employees' files and to try to get a written description of its restraint technique and to look at other training options if they can't. Meanwhile, children at NGU are being restrained by staff with this questionable training on a near daily basis. I would like to provide a copy of NDOC's complaint and of HCQC's corrective action plan to the Commission. We will continue to monitor this facility, and we're available to provide a report on our activities to the Commission as well. In the interim, I urge you to take whatever urgent action is within your purview to ensure the health and safety of these children, which we believe is in immediate jeopardy. Thank you.
Thank you for your comment. Do we have anyone else with public comment at this time?
Hello?
Seeing and hearing none, we move. Did we have one more?
Yes. One moment, please.
Hey, Braden, you may also want, this is Commissioner Reesley, you may want to check chat because it looks like you may have some pop-up public comment there as well.
Okay.
Hello? Hi.
Hello?
Can you hear us?
Yeah.
Okay. So yes, we're one of the parents that had our child here at NGU, and we just wanted to share our comment as well. You know, we started off at this facility just wanting our child to come and get treatment to get better, and this whole process, you know, has caused a lot of trauma, not just to him but our family. We feel that that the lack of staffing and the lack of communication and the lack of you know treatment that was given it didn't make any improvements for our child. Rather, it made things worse. Do you want to share something?
No, we were notified by staff in Never Give Up that you know, about a lot of disturbing stuff that was going on over there towards the end that caused us to pull him out. And you know, we were notified by you know, we actually got some phone calls secretly, anonymously from staff, and that were very disturbing and still need to be investigated to this day. And you know, that caused us to pull him out. And it's just unfortunate because our son still needs treatment, and to this day, and you know, it just wasn't properly being given to him there, and all the other children, we believe,
Need some kind of advocacy.
and who need the same kind of advocacy. I'm sorry. And you know, we just hope that there's further investigation towards this, because we believe there's a lot more to find out. Maybe.
Oh.
Thank you for your comment. I appreciate that. All right. Do we have anybody else with public comment? I see at least one other hand up. Catherine, Katie? You're on mute.
Thank you. I apologize. To the parents who just spoke about their son at Never Give Up, if you could give your name for the minutes, that would be wonderful.
Veronica Benavides and Felix Benavides.
Thank you so much.
Thank you. And just as a reminder for anybody with public comment today, please state your name, first and last name for the record. It's necessary for public record or public comments. I see some hands up on my screen is Breanne.
Yeah. Yes.
Breanne, you have 2 minutes for public comment.
All right. I was a patient at NGU, and I have a broken toe. I have scars from NGU that have in the restraints. They have put scars on me from the restraints. They I was like not aware, so it was like faded out. So I barely remember, but I was in a restraint, and somehow they broke my toe, so I have to be wearing this brace, so it's like still broken. It I keep re-injuring it by accident, but they have caused a lot of trauma and a lot of trauma from that. But that's it.
Thank you for your comment, Breanne. I see and I hope I pronounced this correctly, Gesena Zimmerman.
Hi, you did pronounce it correctly, and I appreciate that. I just want to say I have a daughter currently in NGU. We've been looking to move her for quite some time with little to no help from NGU to go ahead and transfer her to another facility. As a matter of fact, they've probably done more to deter any kind of transfer to a viable facility for her. She's been there 2 years. She's gotten absolutely worse. I've heard that NGU, I've read they have a plan to modify treatment based on clients' clinical needs. My problem with that is currently NGU does not have a treatment plan. There's nothing to modify. They have consistently described my daughter's behaviors to me and have been unable or unwilling to describe any kind of treatment around dealing with those facilities, with those behaviors. At my continued request for documentation regarding what their remediation and programming looks like, I am taken offline to discuss. I am provided zero answers other than we can't force a child into treatment. And so my problem with all of this is while my daughter gets worse after 2 years and after a lack of anywhere to place a child in her situation, her window of opportunity for improvement in her life and in her mental health is closing. And I blame NGU 100% for perpetuating the issues she has. Thank you for your time.
Thank you for your comment today. Do we have any other comments at this time?
Yes, my name is Eliza Bowen. Can you hear me?
Eliza, you have 2 minutes.
Yes.
Yes, Eliza, you have 2 minutes.
Okay, I'm a future employee at NGU, and I was there for about 2 months. And the things I've witnessed is like mental abuse, physical abuse, emotional abuse, and just the way they care for the kids is just not what they portray to the people that's not in there. They leave the kids with the same clothes on all day. They go to sleep in the clothes that they woke up in and been wearing all day, running around. The first thing they do when they wake up is just go straight to a classroom. They don't even wake up and brush their teeth, go down. The food there is, they said they have a nutritionist. I'm not sure where that's at or where it comes into play, but the food they feed them is, I even sat there one time and ate every meal they ate and I was still hungry. So it's like, if I'm still hungry, I know grown kids are still hungry. And like in the morning or at nighttime, say a kid doesn't want to get up, they're like, well, force them to get up. You're just going to have to drag them out the bed. Or if a kid's like nighttime, they give them all their medicine. They're like, oh, just let the meds take control. You know, like, and then they threaten them constantly with a Benadryl shot. They call it booty juice. So they're like using scare tactics to get to the kids. The kids will tell them repeatedly about something, they will ignore them, and it's just not right. I feel like it's a lot of hurting people, honestly. And the kids don't have no right to speak up for themselves. They're treated like animals. People in juvenile hall are being treated better than people at NGU. And that's my experience. And when I started speaking up too, I honestly almost forgot, I'm sorry, it might be a little over 2 minutes, but when I started speaking up on what I was seeing, they honestly fired me for the dumbest reason. Like, they fired me for something that happened outside of work. And that, I feel like that was just because I was the only one that started speaking up.
Eliza?
And then
Eliza?
Yeah.
We've reached 2 minutes.
Okay.
Thank you for your comment. Do we have any other public comments at this time? Seeing and hearing none, we will close out public comment. and move on to agenda item number 3 for possible action. November 9th meeting. Commissioners, do you all have a chance to review, and do we have any a motion or any concerns or discussion before we move forward?
Yes, I would like to speak for Never Give Up.
We're on a new agenda item at this time.
Oh, okay. Never mind.
It's for meetings.
Good morning. This is Jennifer Spencer with the Attorney General's Office. I think it's the chair's discretion as to whether you would like to reopen up the public comment at this time. But if not, there is a second public comment section at the end of the meeting that participants can also speak up at. Thank you.
Thank you, Jennifer. Knowing that, I will place the agenda item number 3 back into queue, and we will reopen agenda item number 2 for public comment. Was there somebody who wanted to have a public comment? We will then reclose public comment and save any additional public comments for towards the end in the second public comment moment. Again, for possible action, approval of the September 9th, 2022 meeting minutes. Do we have any comment on those from any of the commissioners? Would anybody like to make a motion?
This is Commissioner Cooper. I would move to accept the minutes as written.
This is Commissioner Giron. I second that.
All in favor, aye?
Aye.
Aye.
Okay, excuse me. Thank you, Commissioner Giron. All in favor, say aye. Any ayes? Any abstentions? All right, the minutes for September 9th, 2022 are approved as submitted. Agenda item number 4 for possible action, the 2023 meeting schedule for proposed dates of January, April, June, and September. Does anybody have any with those from the commission? Catherine?
Good morning, everyone. Thank you for looking at the proposed agenda for next year as far as our meeting dates. The meeting dates that are proposed are the ones that follow closely to the meeting dates for 2022, with the exception of the June meeting date being moved to earlier in the month. And if you have any questions, please feel free to let us know.
This is Commissioner Cooper. Looking at the dates, I don't have a problem with any of those dates. I do think it's quite a long time to go from September until January without a meeting. So I don't know if we wanted to add another. I know with holidays, things are crazy. But as we're seeing, we might need to meet a little bit with a little more frequency. So I would not be opposed to adding another maybe November meeting in there if that's possible.
I would agree with that.
Catherine, this is Catherine Martin for the record.
I believe we could.
If we look at, in looking at the November dates for 2023, the first Thursday of November is November 2nd. Then the second Thursday of November is November 9th, which is right before Veterans Day. And then the third Thursday of November would be November 16th. If the commissioners would like, we could add the first Thursday of November, November 2nd, which would keep us from having any difficulties with holidays.
I think the November 2nd date is a good date.
Agreed.
Would anybody like to make a motion which includes November 2nd, 2023 at 9 a.m.?
This is Commissioner Cooper. I will make a motion to set the calendar for next year with the dates of January, April, June, September, and November.
This is
Anybody like the second?
Commissioner Giron, I'd like to second that.
All right. All in favor of the meeting schedule for 2023, aye? Aye.
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 Any nays? Any abstentions? All right. The agenda item is closed for approval, or with approval for the agenda item, or the meeting dates for 2023. Excuse me. We're going to move on to agenda item number 4 for possible action. Update on commissioner concerns, including suggestions and possible recommendations regarding seclusion and restraint report from Never Give Up Youth Healing Center facility. Daniel Cox, I believe, is on for today. And before Mr. Cox or the NGU representative steps forward, what I ask, please, I know this is a topic of great interest to the commission and clearly from public comment to many others. This is an opportunity for Never Give Up to respond to those questions that were proposed during the last meeting and are within the scope of the commission. There are regulatory bodies and others who have a different scope, and so what I ask is that Never Give Up be given the opportunity to be able to provide answers to the questions that were shared with the commission during the last meeting. And we do ask for some decorum to allow them the chance to answer those questions uninterrupted. Mr. Cox or a representative from Never Give Up, the floor is yours.
Thank you. For the record, Daniel Cox with Never Give Up. Chair Schrag and the commissioners, we appreciate the opportunity to speak with you all today. One of the things that I would like to clarify, Chair Schrag, is we have laid out a response that we intend to present and allow for that presentation to roll through. Would that be appropriate, or would you rather take on a different form, Chair Schrag?
No, you know the 4 questions that we have recommended. Are you on camera or are you on phone today?
Oh, I can be on camera. Yeah.
Okay. Yes, please. Thank you. It's hard to tell sometimes if it's a phone. No, the floor is yours to. I know we've provided Mr. Cox that information. You know, we've laid out those questions, and as we discussed before, this is an opportunity for you to provide that comprehensive response. And so this is your time. If there's anything from one of the commissioners that is needed for further clarification, we will step in at that time. But as of now, the commissioners are the only ones who will ask additional further questions. And as of now, the floor is yours, sir.
Thank you, Chair Schrag. Appreciate the clarification. One of the 3 areas that I have here, the Commission on Behavioral Health's request for a presentation was first on the area of the length of stay. Second, reviews of seclusion and restraints. The third, physician or physician designees attending to the clients after incidents. In the first area, length of stay, the length of stay is concerning, given the standard of care is to treat children in the least restrictive manner as possible. Decreasing the overall length of stay within a strengthened Nevada system of care would be the objective. In addition to that, evidence supporting longer programmatic commitments is necessary with viable and tangible outcomes. In the section of review and seclusion and restraints, the commission noted documentation or evidence of the treatment plans being adjusted to help mitigate repeating incidences is the concern. Clients experience similar events or incidences, but the lack of documentation of the treatment plan modification was noted as the concern. In this area, strengthening individualized plans to be modified to address repeating incidences is necessary. The implementation of a trauma-informed models, which is the sanctuary model that we've chosen to implement, and also moving to strengthen our integration of our person-centered stratified treatment system will also address this particular area of concern as well. In the third area, physician designees of attending to the clients after incidences, the commission noted that incident reports lacking documentation of the physician or physician's designee to attend to a child and see them within 24 hours of an incident. However, the reports are lacking in documentation of that. The internal process of the physician or the physician's designee's review and signature of review for incidences is beyond the 24 hours. In this area, improving internal processes to meet the standard of care is necessary. Ensuring consistent physician and physician designee oversight is necessary as well. An increased the program's medical department's capacity is based on census is an active step that must be taken. Briefly, we would like to speak mainly to the stakeholders' interest and in this particular area of seclusion and restraints. One thing that we want to bring to light is that the state of Nevada has many external agencies that have regulatory responsibility over a psychiatric residential treatment facility. And in our experience, we have taken a lot of great insight and collaboration from these external agencies, namely HCQC, the state licensing agency, has been very thorough. Their investigators are trained investigators. They are collaborative and professional. Their investigations of any complaints that are made at the facility level regarding seclusions and restraints are very well done. They conduct thorough interviews with the clients. They have complete access to the entire facility at any given time of the day or the week. They conduct unannounced visits frequently to the facility, and they speak with staff. They review every single area of the program, from food, from interactions of the staff, training, and their investigations have been able to provide continued insight for us to improve the quality of care for the clients that are receiving treatment at Never Give Up. I would speak to their acceptance of any plan of correction as an appropriate acceptance. Their qualified staff members and investigators are able to review things against federal law, state law, and compare those with accreditation standards as well, international accreditation standards. And when HCQC state licensing accepts a plan of correction, it's done with the utmost review and with all regulations taken into account, especially with client safety being their main target. Stakeholders, in addition to that, DCFS have provided extensive oversight of the seclusion and restraints at the facility. This commission as well has been able to receive reports regarding seclusion and restraints, which is the basis of this particular presentation, and has provided continued oversight to provide the facility information and insights to improve quality of care as well. From there, other stakeholders have questionable ethical approaches to their advocacy of the clients, and working with the Nevada Ethics and Loss Department and agency, we will continue to review those practices and in the way in which they've inserted themselves throughout the facility. And we continue to take note that the external agencies of the state of Nevada have been able to provide the appropriate regulatory oversight of seclusion and restraints. We feel like there's been a lot of collaborative steps, including with Nevada Medicaid, to continue to evaluate the services that are being reviewed or received by the clients at the facility, to work on reducing the volume and the length of time in restraints, and to also take into account the acuity of the population in which is served. We recognize that the pandemic and a number of other factors has continued to increase the acuity of the children in the community. And the state of Nevada has also seen an increased attention on mental health, given the Department of Justice's recent report that has been issued to the state of Nevada to improve their system of care and their community resources. One of the things that the state of Nevada was able to receive as a response or in an effort to respond and prepare for the Department of Justice's report was access to tens of millions of dollars to be able to increase and strengthen and build out their system of care. As Never Give Up has maintained the same reimbursement rate since 2017. Regardless of inflation and changing requirements and expectations to the services that need to be provided to the clients. And Nevada Medicaid has been responsive and appropriate to a review of those rates. And we feel it is just as important for our facility to continue to evaluate that area, just as the state of Nevada has identified that as their main need to be able to correct their system of care. We also feel that we're in step with them on making sure that we can address the acuity of care by working with the state of Nevada and the Medicaid division to improve the services in which we can provide. One other point that, or a major area that we'd like to address and present is the sanctuary model of care. In the three areas that the commission asked us to speak on, the sanctuary model of care has been recently reintroduced to the facility. It is in its beginning implementation stages, along with other evidence-based practices such as motivational interviewing, social emotional learning platforms, and other programmatic changes that we have only recently started to take on outside of seeing that rate increase that we identified as needed to increase those program areas. The facility has taken a lot of steps in that area and feel that the sanctuary model of care will be able to provide a lot of answers to the areas that the commission has identified. For this particular section, I'd like to hand this over to Michael Spindler, licensed clinical social worker and clinical lead with over 40 years of residential experience, to be able to discuss the sanctuary model of care. Michael.
Yep, thank you. Thank you, Mr. Chairman. I have been responsible for the training of staff in the sanctuary model of care at Never Give Up. That's an ongoing process. We began the training last summer and really concluded much of it around Labor Day. And we are doing and initiating another round actually Monday, bringing in support services such as our admissions department, our human resources department, and the new hires is part of the onboarding process. So the training really is an ongoing phenomenon. It doesn't really stop. At our last meeting, Mr. Chair, you will recall I began to talk a little bit about the sanctuary model, but unfortunately we ran out of time. So some of what I'm about to talk about and describe is perhaps a little redundant, but it will provide, I think, appropriate and helpful context so everybody and all of our stakeholders will understand how the model works and what it's designed to accomplish. So if you will bear with me, I did prepare a brief presentation that I'd like to go through, and then I'm happy to respond to any questions. Never Give Up Youth Healing Center, the largest state licensed and CARF accredited provider of psychiatric residential treatment beds in Nevada, has implemented the sanctuary model of care. The sanctuary model of care was developed in the 1980s by Dr. Sandra Bloom while working at an inpatient psychiatric hospital in Philadelphia. The sanctuary model of care is predicated on the clinical understanding that trauma is almost always at the core of mental illness. This is particularly true when trauma occurs in childhood. The sanctuary model is among the very first trauma-informed approaches to understanding mental illness and treatment. Today, there are more than 500 residential treatment facilities in the United States utilizing the sanctuary model of care. Sanctuary is not a clinical model, but rather a cultural model of care. Sanctuary focuses on re-traumatization and its antecedents, the emotional impact of re-traumatization, secondary traumatic stress on staff, sometimes called vicarious traumatization, and the importance of developing a nonviolent, non-coercive culture in the program. It's a trauma-informed, trauma-responsive, and whole community approach to creating and changing an organizational culture. The building blocks of this model are the 7 sanctuary commitments. Those commitments include growth and change, nonviolence, both physical and verbal, emotional intelligence, that is developing an understanding and empathy for others, social learning, open, honest, and transparent communication with others, social responsibility for one another, and democracy, that is shared power and decision-making. Sanctuary-informed programs are strong, resilient, cohesive, and nonviolent. Staff must trust one another and always put the needs of children first. The program must be democratic and power must be shared. Staff and children must find their voice and be provided with opportunities to be heard. Staff must be able to manage their own emotions. Communication must be open, direct, honest, and without fear of retaliation. Conflict must be addressed in an atmosphere of safety and used as an opportunity for growth. The sanctuary model relies on a number of tools to help youth develop enhanced coping skills. They include twice daily community meetings designed to help clients develop a better capacity to put feelings into words. Meetings assist in the developing of a client's capacity to receive and provide social and emotional support from others. All youth must develop written safety plans. Safety plans require each client to identify 3 simple activities they can employ when feeling emotionally overwhelmed to avoid engaging in unsafe, out of control, or toxic behavior. Each activity constitutes a self-soothing or coping mechanism and healthy alternative to maladaptive expressions of feelings. Safety plans are designed to help youth achieve the skills necessary to regulate their own emotional state and constitute a cognitive and behavioral tool for clients. An additional element of the Sanctuary Informed program are red flag meetings. Red flag meetings are called when a staff member wants to bring an issue to the attention of the community. Red flag meetings may involve a youth in crisis, a collective disturbance, an untoward incident, or any other issue the community must respond to as a group. Red flag meetings can be called by any staff member and are always attended by campus leadership, the treatment team, and all other relevant stakeholders. Red flag meetings are a whole community approach to solving problems, deconstructing critical incidents, initiating necessary programmatic changes, or reviewing treatment planning for youth who may be experiencing sustained emotional dysregulation. An additional structural change to the program is the introduction of planning and service review meetings. Once a client reaches their 9th month of care, they will automatically be placed on the agenda for a planning and service review meeting. This meeting constitutes an opportunity for the clinical team, along with leadership, to review and determine if a child requires continued care or if that client can be discharged to a lower level of care or possibly return home. Extensions of placement must be justified and will only be approved on the basis of clinical evidence, documented behavior, and measurable outcomes. Planning and service review is an additional opportunity for the team to adjust or modify treatment planning for a child. The monitoring of these reviews will be the responsibility of our compliance and quality assurance departments and memorialized. We anticipate this process will culminate in reduced time in care for our clients. Red flag meetings and planning and service review meetings function concurrently with monthly treatment conferences that are held on each child in care. The outcomes we hope to see through the implementation of the sanctuary model of care include reduced restraints, reduced duration of restraints, decreased critical incidents, decreased use of timeout, which we now call sanctuary space, decreased acute hospitalizations, reduced lengths of care, and reduced staff turnover. Our quality assurance department is collecting data, including the anticipated outcomes identified in this brief presentation, to assess the impact of sanctuary and to continue to inform our practice at Never Give Up Youth Healing Center. That concludes my presentation and remarks.
Thank you, Michael. Daniel Cox again for the record. like to continue to just discuss a little bit about residential treatment, as the commission might have commissioners that have been able to have lived experience in residential treatment, or has been administrators or potentially staff members in a residential care setting. There hopefully is some reference point to what this particular level of care is. To those that are advocacy agencies, hopefully are able to have individuals that are amongst them that have been able to be a part of a residential treatment in its entirety, to be a part of the daily management programming in other areas as well. And for others that are stakeholders, including parents and staff members and clients, the residential treatment model level of care is a very extensive and complicated model of care. You're running virtually a mini city in its own way, from everything from start to finish. And these particular areas that the commission has requested for review are not necessarily able to be addressed with just a sole focus on those areas. The sanctuary model of care, as Mr. Spindler identified, is a cultural change to the residential treatment model, to be able to integrate with direct care staff. As we heard in public comment, there's staff members that become a part of the therapeutic milieu that will need to be more heavily supported, that need to be given a stronger voice to be able to make an impact and be a part of the therapeutic opportunities and activities that the clients are experiencing, as well as the clients to be given a stronger voice as well, and parents to be able to engage at a stronger level with the staff members that are providing those direct care services to their clients. The biggest challenge that a residential treatment facility has is their direct care staff. The direct care staff come in with their previous experience, whether it could be emotional, it could be that they need to be trained in what the residential care model looks like, and conclusions that they reach are sometimes justified and unjustified in their own way. And the sanctuary model of care is democratic in its approach to be able to share those particular concerns and to be able to provide a platform to educate the clients and the staff and administration, as well as stakeholders, on how to go about providing the best level of care for the children. So as we continue to implement the model of care, there's other program priorities that must be addressed as the residential care model is extensive. We have 8 currently identified priorities that we're working on with the program. Priority 1 is leadership. Priority 2, staffing and HR-based activities. Priority 3, admissions and discharges. Priority 4, programming and student engagement. Priority 5, medical and safety. Priority 6 is documentation. Priority 7 is the facility in general. And priority 8 is behavioral tools. To talk about each of those priorities, again, the way in which we're approaching this presentation to the commission is to say that the length of stay concern, the review of seclusion and restraints concern, and the physician and the physician designee's attendance to children after incidences is more holistic in nature. The company, the facility, the administration, the direct care staff have to be able to be approached at a holistic manner to be able to achieve what the commission is looking for. These 8 priorities, along with the sanctuary model of care and our continued collaboration with Medicaid, with HCQC, who are partners, who are agencies that understand the need for this residential level of care, who are there to provide a path forward and not barriers to prevent children in the state of Nevada to receive this level of care. We're working, of course, also with DCFS, who is very, very involved in the rehaul of the system of care. and residential treatment will remain a part of that system of care. And our intention is to decrease the length of stay. So as the system of care that Nevada is working to build can be able to support children in the community at a higher level, which is something that we faced for the last 5.5 years of not having resources to refer, to not have the resources that are needed to, one, prevent the length of stay from being long, two, to even prevent the client from coming into the facility, and third, during the discharge process, as the parent who shared in the comment section, there is lack of resources in the state of Nevada, and that is detrimental to the clients in their reintegration into the community. Specifically on the priority 1 of leadership, we need to work to support and strengthen main leadership, complete continued development plans to ensure that the facility leadership is well equipped to continue to navigate the regulatory environment of the state of Nevada and to be able to meet the needs of the clients and the parents while providing this level of care. One of the things that I'll say as we go over these program priorities in the sanctuary model of care is that as a facility, we are at this point because, again, the pandemic and the regulatory changes have changed the environment in which we provide services. It's time for the facility to recognize that it needs to actively be engaged with our community stakeholders to be able to adjust its approach, to be able to meet the needs of the clients, and to dwell on what the past held and how we were working and operating within that model would be unfruitful in its own way. However, we must take that information to be able to craft what the future activities and action steps will be. Things have changed, right? And as those things have changed, the facility has been unable to be able to identify the resources in the community that it needed to be able to access the funding that it would need to increase its staff training and its integration of program oversight. And I think the state of Nevada in a whole has seen that as an issue for themselves. And the Department of Justice's report has made that blaringly obvious that the state of Nevada has stood true to its ranking as 51st in mental health and access to care. And Never Give Up's intention is to be a solution to that access to care and to work alongside of the state of Nevada to develop a program that will be able to turn out the outcomes that this state needs and the clients deserve and the parents are seeking. So again, on leadership, we need to continue to support position roles, to clarify those roles and increase their ability to make actionable steps and decisions within daily programming, increase their daily presence amongst the therapeutic milieu, spread the main leadership throughout the programming, and increase their availability to clients. This addresses things like length of stay and review of seclusion and restraints and the integration of professional staff to attend clients after an incident, because the leadership is being able to be available to the clients and spread throughout the milieu to identify those concerns and act quickly to increase their internal communication. Additionally, assigning leadership to external stakeholders to increase the sharing of information is necessary so that we can demystify what happens at the facility. And we are not a closed facility in any way. We're always open to regulatory agencies or stakeholders coming to the facility. The commission is welcome to come and tour as well at any time that they see fit. But we want to make sure that our leadership are assigned to external stakeholders so that they can be given the information at a quicker pace. Priority 2, again, in staffing and HR, programming leadership needs to increase their initial vetting and onboarding of staff. So we can prevent the experience that some of the staff members shared in public comment, that they can be strengthened in their onboarding experience, their training, and their program integration, to be able to review and develop the staffing schedules to reduce burnout and turnover. There's, excuse me on my voice, losing it. there's a strong need to make sure that there's a reduced burnout and turnover, so that the staff are always at their best possible state to provide the care to the clients. Again, this addressed lengths of stay and review of seclusion and restraints, and ensuring that the professional staff attend to clients because the staff are able to be attentive and cognitive of what is needed of the clients at the time of incidences. Priority 3 in discharges and admissions, we want to work harder on stakeholder education on the admissions criteria. We currently have close to an 80% denial of all referrals that we receive for our program. I share this just as an indication that, as some might have pointed out or alluded to or made claim that this facility is concerned about the financial ends to providing this service, we deny over 80% of our referrals because we are constantly screening for admission criteria to ensure that any client that comes to the facility, that we can appropriately care for them. It's also an indication of how drastically under resourced the state of Nevada is, that if we're receiving, say, upwards of 40 referrals in a month, which we have, or even 60 referrals in a month, and we're denying 80% of those referrals, the question that we would have to ask ourselves is, where are those clients going to then receive services, which would be out of the state of Nevada, or they would languish in ERs or psychiatric acute hospitals because there's not enough residential-based services. So Never Give Up must increase its ability to be a better provider for the state of Nevada, so that the clients at least have this option to continue to come to for residential services as the system of care is rehauled in the state of Nevada. We also want to ensure that we increase client integration into the program as they come into the program, to ensure that they understand the way in which staff will interact with them. What is good, what is not good? When should they seek for advocacy? When should they seek for the grievance process to be initiated? When should their voice be heard, and how fast should they make that happen? So increasing their client integration. Stakeholder education also on discharge criteria is necessary. We want to also establish better, stronger relationship with community providers as the system of care is built out. We must be able to quickly integrate with those community providers so that the discharge back into the community is successful. Programming and staff engagement on priority 4. The sanctuary model, we want to continue to educate also the use of the sanctuary unit, education on it and the use of it. It's de-escalation spaces. We made a big shift from what we used to refer to as our observation unit, which was more or less a reset that the staff were engaging with the clients to be able to come back in to the general programming. But the sanctuary unit is being fully designed to be a unit that supports continued or increased needs of a client, or self or client driven needs, where some clients simply need to decrease the stimuli that's in the environment of general programming units. There's a lot that goes on when there's 10 kids in a particular programming unit, and some clients need the option to be able to decrease that stimuli, and the sanctuary units are de-escalation spaces for them. It also helps to safely prioritize behavioral interventions for those clients. Primarily, again, it can be client driven so that they can self-regulate. Removing clients from programming units is not a maladaptive behavior. It's an adaptive strategy to introduce self-coping techniques. It's not seclusion. And so in the reintegration, or I would say the introduction of the sanctuary unit as it continues to unfold in its development, we want to make sure that the clients have a clear understanding of the way that they can use those de-escalation spaces appropriately. We want to also increase therapeutic engagement with staff, with clients, so that staff members aren't treating administration as the only way in which clients are being engaged throughout the program. Staff tend to gravitate towards administration as the cause for the client's outcomes. And we want administration to continue to work to empower the staff to be engaged in those therapeutic opportunities Specific programming as well for age groups and needs is going to help to decrease lengths of stay where we'll be able to address the client's needs quicker in a more age-appropriate manner. So specific programming will continue to be a priority for us. It will also reduce the restraints and other areas that are happening as well. Reviewing professional staffing schedules to ensure strong coverage throughout the week to support direct care staff. Direct care staff meaning like the staff members who provided comment. We want to make sure that there's access to those professional staff so that direct care staff can engage with them, ask them questions, be given tools in which they can then go and make an impact with the clients that are receiving services. Improve the therapeutic community is also another prong to our priority 4. Improving the therapeutic community in social interactions, activities, vocational training opportunities, and program input from clients. As we improve that therapeutic community, the length of stays also will decrease, and so will restraints. And those are areas in which we feel will address the Commission's concerns. Priority 5, medical and safety. In Armagosa, it's a remote location. Lots of benefits to that. The clients can come out there. They are away from that stimuli of the city, but there's also a lot of complications with that when it comes to access to a lot of different services that you would find, miles away from a facility that's just in the city. So ensuring that we combine online and on-site resources, engaging again with the Board of Pharmacy to improve medical dispensary management will be important. That will help to make sure that restraints aren't occurring repeatedly for the same clients. And also increasing additional staff authorized to provide that medication management. Developing a strong community provider relationship to improve outside treatment and follow up on medical issues such as dental and vision or simple injuries that might occur from playing basketball or being out at our facility, which is a very open facility, has outdoor basketball courts, fields, and a lot of opportunity to be out in the nature, and that can sometimes result in injury. And so making sure that we spend more time in the community to identify those community provider relationships that can strengthen our response to medical needs. Reviewing professional staff schedules again in this area to ensure timely evaluation and treatment, which would address number 3 is making sure the physician and or the physician designee is available to attend to the client. And so spreading those professional staff throughout the day, the week, and the program is important. Priority 6 in documentation, increasing training for direct care documentation. Direct care staff have, if they're involved in the incident, it is their sole responsibility and to be able to articulate what they did, what de-escalation steps they took, and their interaction with the client, what justified their reason to provide a physical hold according to the training that they received. And so making sure we're increasing the training for the direct care documentation, providing potential chart examples or also scenarios that they can then attempt to write to so that they can be evaluated to improve their documentation. Increasing the internal audit cycles will also help with this with immediate remediation. So things like reviewing treatment plans to make sure they're being modified as restraints are occurring. So the Commission will hopefully see a lot of benefit to that the treatment plans are being adjusted as restraints are occurring so that we can decrease those and the client can receive a different approach to their treatment. So those internal audit cycles with immediate remediation will be important. On priority 7 facility, the weekly walkthroughs to document all damages, any safety concerns, also softening the programming environment to achieve a more living room model or more community-based feel is something that we want to work towards. We've done, over $1 million in the last month or so, or 2 or 3 months to improve just the basic facility. But at this point, it's moving into now softening that particular programming environment to provide a better feel for the clients to feel more in a sanctuary model trauma-informed space. And that will also help to decrease the restraints and provide a better environment for them to be in while they receive services. In priority 8, behavioral tools. Training additional de-escalation tools and techniques will constantly be an effort on the facility's stand. There's always new and upcoming things that are coming out, and the facility will continue to seek those out to provide additional de-escalation tools and techniques to the direct care staff. Refining the incident log with regular trend analysis will be important as well. That will, much like the commission does, watching trends of the same client over and over, we can catch that sooner and provide an intervention at a quicker pace with a refined incident log, so that the treatment plan can be modified and the client can receive the additional services and needs that are being identified. Again, continuing to provide additional training on therapeutic physical interventions with practice sessions monthly to create a sense of confidence in their physical skills. Making sure that the staff members truly understand what they need to do in a situation, how to apply those physical skills so that it's safe. I know that the commission, and I would hope advocacy agencies and others know that physical restraints are not done in a perfect world, that clients do fight back, that staff struggle to maintain the hold in which is safe, and that in all of the physical intervention trainings that you'll find, we'll talk about the need for the staff members to quickly make adjustments, to seek additional staff member help to ensure that the physical skills are being applied appropriately, but they are dynamic in nature. It is not perfect, and it is a risk. Every time a physical intervention occurs, there's risk to everyone involved, and the additional training so that the clients can continue to feel more confident and ready and prepared if that particular need comes up, will make those outcomes that much more successful and reduce any potential harm to the client. So there's a lot of need for those behavioral tools to be continually reviewed, trained, and addressed. Reducing primary and secondary trauma is a huge area of concern for us. We are implementing the sanctuary model of care, which is a trauma-informed model. The whole intent is to continue to integrate that cultural change into the facility so that we can reduce that primary trauma that might have occurred to the client before they enter the facility, but also not to introduce yet more secondary trauma. So the safety plans that Mr. Spindler spoke to is asking the client, what is going on with you specifically when a physical hold is occurring? What do you need from staff members to know that if they were to engage with you on in a physical hold for your safety, what do you need them to know in your safety plan? You know, is there trauma of being physically harmed in your past, so that the staff members know how they can approach that particular client? This will reduce the length of the physical holds, could potentially eliminate the actual use of the hold if the safety plan is utilized appropriately by direct care staff. So that secondary trauma also occurs at the staff level. Every time they engage in a physical intervention, it's trauma-based for them as well. And so our intention is to continue to refine that process for them and to increase confidence and training and demystify that interaction by letting clients and staff talk about what they need in those situations, and increase the debriefing that occurs after each incident so that the client and the staff can sit down and debrief those scenarios. And that will also reduce future restraints as the rapport is built with those clients and the staff members that are providing direct care. So overall, those are the 8 priorities along with the model, sanctuary model of care. Of course, we have a lot of activities that we're engaged with Medicaid and with our state licensing that we're continually working on as well. And we'll continue to approach this in a holistic manner versus trying to address a simple salient point. in what our efforts are to address the commission's concerns. Yield my time back to the chair.
Okay. If I,
sorry, Michael.
yeah, I'd like just a quick couple of follow-up comments, if I can, Chairman. As Daniel pointed out, one of the key elements of the sanctuary model is to really help our clients identify their own triggers, what leads them to become emotionally dysregulated. And that naturally goes hand in hand with helping our young people develop appropriate coping mechanisms. We are, as Daniel pointed out earlier, really at the beginning stages of the implementation process, and candidly, it takes at least 6 months to integrate the sanctuary model into the fabric of the facility. So it does take a little bit of time. We are in the process right now of building a really robust in-service training program, particularly designed for our direct care staff, our youth mentors. We have already created a venue for our children to meet regularly with leadership, to talk about their concerns, their issues, their complaints, the food, what they like, what they don't like, because as part of the model, naturally, the opportunity to express yourself and have a voice in the program, particularly as the consumer, is vitally important, and we recognize it. We have created and initiated a bi-weekly support group for our parents who have children in care. It actually is launching next Wednesday night after work at our outpatient location on Jones Boulevard, the purpose of which is to enhance communication between our parents and staff from the facility. And that's an open invitation to any parent that would like to attend as frequently as they would like to attend. And as I said, that is going to be beginning next Wednesday night. We are at the very beginning of collecting data, but for purposes of this meeting, I was able to find out through our data collection that over the initial 3 weeks in October, beginning October 1 through yesterday, we've actually experienced a 40% reduction in restraints. It's a very short period of time. It is certainly not emblematic of anything that constitutes a longitudinal study, but we'll take it. It's very encouraging, and we hope that this is a harbinger of ongoing and continued reduction in restraints. As Daniel pointed out, restraining a child is traumatizing for the child, is traumatizing for the staff, and our preference is to never do it. So we are committed to bringing that number of restraints down and the duration of restraints as well. I yield back to the chair.
Thank you very much. Commissioners, questions at this time?
This is Lisa Reesley. I have a host of questions. So maybe I'll just go through a couple of them and then trade places with someone else and pop back on later. I have a couple of background questions. So I apologize if you've already said this before. How long have you been in operation?
The Never Give Up Youth Healing Center program itself started in June of 2017.
Okay. And how many beds are you licensed for?
We originally started being licensed with 91 beds, but recently increased to 144.
When was that increase?
March of this year.
Was that before or after your corrective action plan was issued?
That was before. That was during the transition from previous company structure to a new company structure.
Okay. And so even with the plan of correction that was put in place, the number of beds was not reduced by HCQC?
So just for clarification, the bed increase occurred at March of this year. HCQC's investigation happened through July and August, and the submission of our plan of correction happened at the end of August with their acceptance of it. No change and no conditions placed on our facility license.
Okay. What is your occupancy rate?
Our average census, our current census right now, current census right now is at 52.
Okay. So you have quite a few beds that are open then. The difference between 52 and 144. Are you fully staffed for 144 kids?
No, in residential care, we staff as intakes are coming in. So as the mission committee is reviewing clients and they're being accepted, then HR in tangent with them and in step with them, make sure that the staffing is brought in to be responsive to that particular census as it grows.
Okay. And what is your length of stay? You talked a lot about length of stay, but I don't know that we actually got a number. So what is your length of stay?
Our average length of stay at this point is has been close to the 10-month mark, anywhere from 9 to 12 months.
Okay.
And it depends on what slice of time you take, right? So back in COVID's world, they forced no discharges, and that definitely impacted length of stay averages.
And are you certified in the sanctuary model, or are you pursuing certification?
So Mr. Spindler was trained by Dr. Bloom herself when he was operating facilities back in the East. So he is our qualified sanctuary model of care implementer.
Do you envision certifying the facility as a whole at some point? I know that they do like site certifications. Is that something you anticipate?
Yeah, there's
I would just jump.
Yeah, go ahead, Mike.
I was just going to say that's something that we are looking at. It certainly is an option, but as Dan pointed out, I am a certified trainer, I've actually have a personal relationship with Dr. Bloom, who runs the institute at the Andrews Home in Yonkers, New York. And that's certainly something under consideration.
Yeah, definitely would pursue that.
And what is the status? You are CARF accredited as well, correct?
Yes, correct.
And you are still CARF accredited through all of the okay, so that is still remains in place.
Yeah, so the CARF accreditation also received the same NDLAC report, was able to review and work with outcomes by HCQC in response to allowing us to submit to them a full conformance review of the international standards of care, which we submitted all their requested documentation. They did a review of that in step with what the investigation was turning out and clearing the holes inside of the advocacy report and ultimately issuing us still our full 3-year accreditation with no conditions and no change.
And in terms of your primary source of placement referrals, are they coming? So my understanding is that Clark County Juvenile Justice and Family Services will not make placements in your facility. Is that correct?
They have a vetting process that we have not pursued fully, so that you have to submit a vetting package to them with all of your policies and procedures. They then do a clinical review, their clinical staff do interviews and other things like that. We have not fully pursued that vetting process to the end with them.
DCFS still makes placements at your facility?
Mm-hmm.
And Medicaid is allowing placements at your facility, correct?
Yep. Yep. They are allowing admissions at this time.
Has there been a period of time where they weren't allowing admissions?
During the time that we were working with HCQC, we had worked on basically an admissions hold to allow us the time to go through all the necessary steps that we needed to.
I think that's it. That's what I have for now. So, Braden, if anyone else wants to jump in.
Dr. Giron, did you have any questions?
Thank you, Dr. Giron, for the record. Daniel, what's the ratio of staffing there to the children?
The ratio? Oh, so by Nevada state statute, mainly it states that the facility will ensure an appropriate safe staff ratio according to the needs of the clients. We fluctuate a lot between a 1:3 to 1:4. Sometimes that ratio can be higher. It changes at night as well, just based on typical residential treatment modeling. So, but during the day, you'll find higher ratios than at night, of course.
Dr. Giron, for the record. So first, thank you, Daniel, for that report, and Mr. Spindler for that review of model. So from what I'm learning about your facility, you're going to make these changes, going to implement these efforts to improve, document, to certify, to train, monitor, reduce, restraint. I think these are needed. For my work in facilities with inpatient staff, safety is always the concern. Safety is the bottom line in terms of where we start, and I think the parents and the children will be able to sort of let us know how that proceeds. You implement your changes, and yes, there are many programs and treatment and staff training, and we want to just make sure that those what we see as the commissioners see that those changes implemented in the reports we get, and we want to make sure that there's the follow-up, this idea of treatment plan, this implementation of the model. I'm looking forward to the changes you're talking about.
Thank you, Commissioner. If I may, Chair Schrag, just to talk to Commissioner Giron's statement there, one of the things that I'd like to note is that I want to ensure that the Commission knows that that our efforts in the adjustment of the program was not necessarily just sparked by these particular involvements from external agencies. Medicaid can speak to the fact that we engaged with them all the way back in March of this year, and sometimes even throughout the years in our service since 2017 to talk about sustainability and ensuring that we could continue to increase our program deliverance. And the activity that we did this year was very extensive. We submitted, pages after pages of information to them for review. articulating our desire to increase the services, provide stronger staff involvement at the facility level in response to the changing economic environment and our need to support staff and clients better. And so we were well in our way of doing a lot of programming changes. We had already initiated a multi-million-dollar facility renovation at the beginning of this year in February. That was supposed to spread out, of course, the course of this year. And we had initiated a number of things prior to the different external stakeholders coming in. Now, the main thing here is that there's a changing expectation in mental health, right? The state of Nevada themselves is seeing this, as I keep pointing out. There's a lot of pressure to get this system of care figured out, not tomorrow, but today, right? And we got to get working on it now. And so we've shifted a lot of our energy. And I would say that the facility does not look at the involvement of external agencies, namely regulatory ones, HCQC, Medicaid, DCFS. We value these particular agencies and their continued oversight along with the commission. And as I stated last time, the multidisciplinary nature of this commission needs to be leveraged by our facility in a much better way so that we can move our objectives forward. So just in response to Commissioner Giron, we need to implement. We need to see the results and the outcomes of that implementation. And now we're just shortening the time frame of that implementation based on the entire state's need to act quicker.
Thank you. Commissioner Cooper, did you have a comment or question?
Thank you, Chair. Not yet. I'm formulating a thought, so give me a couple minutes and come back to me.
Are there any other commissioners at this time that have questions or comments?
Dr. Giron, for the record, Daniel, how often are you there, like walking through, sitting there, with your staff? How often are you there, present on the floor, in the kids? You have lunch with them, things like that.
Yeah, thank you. Daniel Cox again, for the record. Apologize if I'm not stating that each time. To answer your question, for myself specifically, of course, when we first established the facility in 2017, I was there all the time and actively on campus at all times. As the years have progressed and the leadership structure has been implemented, there's an executive director and a facility or program director or administrator at the site now. These are positions that I used to hold and now have had staff members be placed in those positions. So, in the last, I would say, if we look at a 3 or 4 month window, I've been there each month. I've been there multiple times each month to walk the facility, be with staff, but currently those direct leaderships of the facility are heavily involved, whereas I spend more time with stakeholders and regulatory agencies and working through some of these other dynamics. Currently, the plan, though, is in the next 60 days to also spend 4 to 5 days a week out there or as needed based on the facilities administration's requests from myself and others. And so this particular implementation phase is going to have a stronger push. As Mr. Spindler said, it can take up to 6 months. We're hoping that if we deploy myself and others, that we can increase that implementation phase. So in short, lots in the beginning, leadership placement allowed for the facility leadership to take over, with me spending more time in regulatory based environments and visiting the campus monthly. But with this new implementation, we'll increase that over the next 60 days. again. So.
This is
Chair
Commissioner
Schrag.
Ruiz. I
Go ahead.
just have a follow-up question. Basically the same question for Mr. Spindler. How much time does he spend on campus?
I'm on the campus 2 days a week.
And are you providing any direct clinical services to children who are enrolled in the program? Or are you just providing oversight of the sanctuary implementation?
I do not provide any services directly to children. My work is in relation to staff and focused primarily on supervision, consultation, etc.
And how long have you been on campus, on site?
I have been involved with this program since 2018.
Has the sanctuary model been being implemented since 2018, or is this
No.
a new thing?
No, it was not. We have begun the implementation of the model. Well, we began the training this past spring. As I mentioned, we concluded the training right around the end of the summer, and we are in the process of implementing it now.
So prior to the sanctuary model implementation, what was your role and responsibility on campus?
It was consultation. It was consultation around cases. It was training of our direct care staff. I provided supervision to and consultation to our clinical staff and our clinical director, administrative consultation and training of some of the administrators.
No further questions right now.
All right. Commissioner Operario.
Commissioner Operario for the record. I'm not sure if this has been asked or answered already. What's the staff mix looks like qualification wise for staff providing direct care?
Thank you, Commissioner Daniel Cox, for the record. Direct care staff, the bulk of the direct care staff that are coming in and providing supervision, what we refer to as youth mentors, they can come in with introductions to the industry, meaning that they might have no particular past experience in residential care, which is an obvious hole in the state of Nevada, given that there isn't a lot of residential care. Since 2017, I would say that we've probably been the sole builder of the residential workforce for the state of Nevada, as we've been able to bring on people and attempt to train them into this particular level of care. So our youth mentors tend to come in, we work with them to train them, understanding that model, which is a complicated task in itself. Beyond that, there's lots of layers of different staff members. We have, of course, our clinical staff, our medical staff, med techs, LPNs, medication managers or providers, the APRN, psychiatric nurse practitioners, our medical director, psychiatrists as well. And we have other staff members that work underneath the therapist to provide social based groups, which we refer to as qualified psychiatric counselors that will provide those skill-based activities for the kids. Most of them are bachelor, master level, or have experience in the residential space.
Thank you. No further question from me.
This is Commissioner Cooper for the record. So how much time are the kiddos getting in front of a licensed professional for mental health services on a daily basis?
On a daily basis, licensed meaning therapist like an LCSW or CPC. Yeah, right now, based on what the clinical staff has determined, those particular kids are set for their weekly session with the therapist and group session as well. There's been a lot of activity to continue to support the interaction that the therapist needs to happen by utilizing the qualified psychiatric counselors to continue doing subgroups to increase that involvement. One of the bigger shifts that we made in the last 2 months was slowly dismantling our reliance on teletherapy that happened during the COVID phase. And so we have terminated our contract with the teletherapy group that we were working with. We've increased on-site therapists, and that way they're directly there on-site and available to the kids during crisis or any other activity that's needed. So our intention is to continue to increase their exposure to those professional staff members, but leveraging also the fact that residential treatment is therapeutic in all aspects. The therapeutic milieu, everything that happens in the residential treatment should be and must be designed to be therapeutic in intervention. So the treatment team is guiding that, and the clinician is guiding that. But exposure to them is an objective of us to increase by continuing to get more on-site therapists available.
This is Chair Schrag for the record. One of the concerns that we had was the length of physical holds, and some of them exceeded an hour. What have you done? What in the time that has been allotted, what have you identified as the driver to that, and what corrective actions have been taken to mitigate that, notwithstanding the new model that's being implemented? But where are you guys at with that?
Thank you, Chair. Daniel Cox again for the record. I would respond to that saying that the actions that we've been able to take in this short time is to provide a change of the environment at the dismantling of the observation unit concept and trying to slowly integrate the sanctuary unit and those de-escalation spaces, making sure that the staff members are really working a lot more on the de-escalation early intervention steps. A lot of times those longer holds are a result of a number of areas failing to intervene quicker, initiating the physical hold in a common space where there's multiple clients that are observing that particular physical hold, and some of those things, making sure that we're doing better at providing that client the space that they need to not feel embarrassed, not feel that they have to take a stronger stance. So the sanctuary unit, I would say, has been the biggest push for us to get right. It's a work in progress right now. It's a huge cultural shift that needs to happen, but we're hoping to see and feel like we've seen some benefits to those. We've also increased the access to the prescribing providers, those that would actually oversee a restraint that goes past and requires an order. And so that interaction with the medical staff and those prescribing providers has been worked on to increase their involvement, to see if we can't intervene in a different way to lower that time that the hold is initiated. Those are some of the initial steps, but the bigger work is what was articulated in the presentation.
Do you have a sense of what was a driver to having those holds so long specifically? I know we're looking at what we're doing to mitigate them on the back end, but what was the driver that resulted in that occurring?
I would say that much like what staff members, the previous staff members mentioned in public comment, the direct care staff were and inappropriately interacting with the clients, not knowing how to de-escalate in a professional manner. They're coming in needing more training, more support. They need to be able to be comfortable with what that looks like when a client goes into a psychiatric episode. The leadership and the facility needing to do a better job at ensuring that they were trained and increasing that training exposure earlier and in more detail. So the direct care staff needed to be, I would say the driving factor was that the direct care staff failed to receive the required support that they needed to be at least moderately competent to interact in a scenario where a kid is in a psychiatric episode. And I know much of the parents that have placed their kids know what that feels like when their kids go into those episodes and how emotionally distraught they can get and how scary that can be for even a parent who has raised that particular kid. And direct care staff coming in, not even knowing a kid and watching that particular episode unfolding can be something that could be, a little bit unnerving for them. And if the facility hasn't done the job that it needed to provide them the context and the training to get them comfortable, then those holds are going to go much longer than they need to because they're not deploying the de-escalation strategies appropriately. So driver force is, as probably Dr. Giron might say in his experience and others in residential, it comes down to training, right? And how comfortable were the staff in that training? And the facility recognizes that it must do better at making sure the direct care staff are supported in their training and onboarding.
All right, I have one additional. Oh, go ahead.
Okay.
Nope.
This is Commissioner Cooper. I appreciate the you coming out and saying that was a misstep on behalf of the agency. One of the things that I've noticed, I'm in charge of training for my own agency. So one of the things that we've noticed is that, yes, we need bodies, but we don't need bodies that don't know what they're doing. So it's putting that training forefront, and the most important part, no matter if we need the bodies or not, needs to be there. I'd be interested to look at what your training plan is for your new staff, because that is, it's no secret you guys have been in the news before that, like, these things have been long coming. So seeing how we're training and how that has changed over the last couple of years in relation to being responsive to the boundary violations, the confidentiality breach, whatever, just the negative interaction between staff and clients. I'd really like to see where your training plan is at now in regards to bringing those new unexperienced staff on board.
Thank you, Commissioner Cooper. Daniel Cox again for the record. One of the things that I would speak to that Commissioner Cooper brings up is that the state of Nevada doesn't have a workforce for this. That is the clear and obvious issue that we face. And as a facility, I think that we have to continually be cognitive of that, making sure that we're always analyzing what can we do better to be able to literally take staff who have no reference point, bring them up to speed to be able to then provide the services that, of course, the state of Nevada needs, being the 51st in mental health for access of care. So workforce is the biggest challenge that the state of Nevada has in whole. I think as we continue to partner, as we continue to collaborate, that the state of Nevada takes a more, not necessarily, they need to be critical, they need to have their oversight, but that they're open to the reality of their workforce and that they allow providers such as us to continue to work with them and receive the support that we need to be able to find a way to build the workforce. In states that have residential care and have been established for hundreds of years, go to New York, go to, these states that have had residential care. they're able to glean workforce that has long experienced residential. They're not faced with the same particular issue that we have and the state of Nevada has right now. You'll see in ARPA funds and some of the work that DCFS is doing is centered around workforce development, right? It is a huge glaring issue that the state of Nevada has, that we just do not have the workforce that comes in with the experience that is required. And so the facility or the provider is left with that particular responsibility to make sure that they lift those particular staff members up. That's it's a hard request. It's a really hard request. And as a facility, and I would say probably Commissioner Cooper can say that they've failed in certain areas in their own world and continue to struggle in their own world. But as a facility, we have to be able to recognize that this is the current environment we're in, and we should celebrate the moment that we're in. The state of Nevada is saying that we are ready to change what's going on here. And that means that providers like us can continue to find ways to get support on workforce development and work with someone like Commissioner Cooper that we can send our training plan to and say, oh, yep, this is the hole that I've experienced in our own agency. Maybe you can consider this, or this is an approach, because the state of Nevada is unique and the staff members are unique in their own way, and we have to train to their particular needs. And that's an area that this facility has to understand. We definitely have to understand that we need to be better at supporting these new, unseasoned staff members that we can't just turn away. I mean, the other irresponsible thought would be, well, I guess we just can't be a provider in the state of Nevada because it doesn't have a workforce. So we'll just let our children be sent out of the state of Nevada. Well, we're here because as an in-state provider, the commission has better chance to have oversight of us, right? And the state licensing has a better chance to have oversight of us. And advocacy groups have a better chance to have, they can just drive to us versus getting on an airplane and going to Florida for some residential facility out there. So if Never Give Up needs to be the pioneer to be able to figure out how to be a provider, an in-state provider in the state of Nevada, that's a task we're taking on. We will take it on. And we have been taking it on, as Commissioner Cooper said, it's no secret, right? We're in the news, and that's because being here allows the state of Nevada to show where it needs to do better in supporting providers, where the providers need to do better at finding out how to navigate this particular state. And the responsibility falls on everyone's shoulder. And right now, all we can do is continue to lean on our stakeholders and be proactive within our internal selves to get this right for Nevada and the children. So,
Dr. Giron, for the record. Just one moment. Yes. And as a commission, we are privileged to monitor many agencies and facilities in our state. We can see the training that that the workforce has in those facilities. I used to be a CPI instructor, so I understand the need for safety and the need for training, and implementing CPI in your workforce, I think, would be a good start. And you're focused on your training. I think that is an essential and necessary step. And I'm thank Commissioner Cooper for making us aware of that.
Thank you, Commissioner Drone. That's one area that we did find. We employed a restraint or physical hold model that just was the wrong choice. It was called Calm Every Storm. Wannabe, I think, spin-off of CPI, and we moved away from a restraint protocol that was a lot better, and thought that Calm Every Storm would provide better results, and it did exactly the opposite. It caused injuries. It caused things that it just was not appropriate for our particular environment. And we have since moved to CPI, as Dr. Giron just mentioned, and that's currently the one that we have identified that would be more appropriate. And this is what the staff are going to be receiving and be supported in moving forward.
This is Chair Schrag. Before there's any further comment, I know we're closing in on our initially scheduled time. I will extend our time this morning as long as we can maintain our quorum. Commissioners, I just want to confirm with all of you at this time that we can extend past the 11 o'clock. All right. All right, we will continue past the 11 o'clock. I want to make sure this is obviously a big issue that, and I've got one more question, and I anticipate that we will have a number of probably public comments towards the end, and I want to make sure that we have an opportunity for those as well. And Mr. Levin, I see that you're on today as well. Once a few folks, I would encourage and offer to you as well as a member of the EPIC staff and part of Never Give Up to also maybe weigh in on some of these. I know we briefly, as I mentioned in the last session, I was initially going to speak with Mr. Cox, but I spoke with Mr. Levin instead, very briefly over the phone, as was discussed, a full disclosure. There was no decision-making made during that call, but I believe Mr. Levin would have some comments to make as well to the commission.
And
I think that's important.
And Mr. Chairman, I also have an additional comment when it's my turn. This is Mike Spindler again.
Well, thank you, Commissioner Schrag, and thank you, to all of the commissioners for making this special meeting today. To discuss really how we can get better, as a facility, and how we can be better for our kids. Just as an introduction, EPIC, which is the greater company, partnered up with Daniel Cox earlier this year to enhance the services in the state of Nevada, specifically to build out a continuum of care, a system of care. When we came to Nevada, we saw there were two types of care being provided. There was inpatient, a lot of inpatient options, some outpatient, some outpatient options, but basically nothing in between. And we found out that some of the larger providers who perhaps would succeed in this space weren't interested in coming into Nevada because of the various levels that were missing, and they wouldn't be able to provide that full system. And so, we came in, and obviously we saw there was a lot to be done. Right away, we started spending, upwards of $1.2 million on capital improvements at the Nevada facility, at the Almagosa facility, as well as enhancing our outpatient services. Once we came in, I started working together with HCQC, DCFS, brought them out to the facility for 2 days and talked about what are the priorities, what do we need to do better for the state. Everyone I spoke with, Medicaid, various other agencies, public, they want the best for our kids, and they don't want less beds in Nevada. They don't want to send the kids out of Nevada. And so I knew that we had people, stakeholders to work together with, and I was encouraged by that. Bottom line, Nevada is 51st in the U.S., and we must get to a better place. And the way to get there, obviously, one of the largest components is staffing, staff training. Not to make this about one item, because there's so many items that we would discuss today, but obviously that workforce is something that we really need to work on, and we need to get there. We need to get there very quickly. The goal of our organization is to reintegrate the kids with their families as fast as possible. And obviously keeping them here in state will help. We are looking at multiple other facilities, step-down options where kids could go to school and come back to a therapeutic milieu environment with various types of group therapy. And we've been working with the various agencies, something that no other private provider has done before, which is involve the agencies at the beginning stages of our plans. Obviously we have some parents, some staff who, didn't get the services that they deserve, that they want, that they need. And I would appreciate if anyone can reach out directly to me. I will leave my email, and I would love to schedule time with anyone and everyone to discuss how we can get better. Like I said, DCFS, this commission has been very upfront with where they believe we need to be better. And that's why you see a tremendous response, a tremendous investment from our company. We're committed to making this work. We're doubly committed, and we will be here for the long run. We will solve these issues. We're not going to cop out, even if it gets tough, even if it gets hard with the many agencies that are involved. There is one agency that I'm asking to collaborate with us. The NDALC has not been collaborative in their nature. And we requested from various people throughout the agency to tell us, talk to us. And here we are today, where we still haven't had that type of relationship. And I say this from the bottom of my heart. I believe that the answer to these kids is not shutting down more programs. I think the answer is working together as the various teams over here assembled, whether it's DCFS, HCQC, even Medicaid, working together to get everybody together in the same room. Something, the commissioner over here and the various commissioners over here have been very upfront about, hey, we need to come, we need to solve this problem. And I appreciate that. And I would appreciate if NDLC would, we would love to have that type of relationship with your agency, as well as you're very focused on the kids over here and on safety and ultimately the outcomes. I know, when I've met with the NDALC members, they do not want to send these kids out of state. They're very focused on the kids. But I think that the way to solve this is to work together, to collaborate as a team. We know, we must get better. We must do this as a team. We are committed to following up with you guys, with this commission, to working with this commission, to bringing you on campus, and to eventually build out the system of care, whether it's with providers that are already here in the state, or bringing in fresh blood. But we will figure a way to wrap around these kids, look at the holistic point of view, with the safety first, obviously, mentality. Safety, making sure that we're de-escalating, we're giving these kids the best care that we can, doing the best that we can with training. And I really believe it won't happen unless we all break down our silos and say, hey, we're going to work this together as a team. So that's my impassioned plea, on that everyone work together. I'm free to give out my time as needed. I will meet with everyone and anyone to hear what I can do, what we can do to be a better provider, not just on one level of care, but all levels of care throughout the entire system, to make this happen, to make this to do better for our kids, because we have to. Thank you for your time. Thank you for inviting me.
Welcome. Ms. Martin, I see your hand is up.
Yes. Yes. Good morning, Chair and Commissioners. We no longer have quorum at this time. It appears that Dr. Giron had to leave the meeting.
Well, that puts us in a quandary to continue. And I know that there were individuals with public comment. If we could get maybe a ruling from the DAG, if there are public comments that can be followed up on, can we put them in the chat at this time and not necessarily discuss them if there's a brief comment to be made and still be okay?
Yes, for public comment, there would be no decision making or voting based on the public comment. So it's just public comment from individuals who are participating today. And I just wanted to check to see if maybe the lack of quorum now is because of a technical issue and we just need to wait for someone to get back on. Is that what's happening?
Can we check with Dr. Giron just to make sure it's not a technical glitch? We'll hit a pause then for right now while we address this. I want to make sure that that we can continue. Because I remember Dr. Giron giving a thumbs up that he could stay past 11, so I'm wondering if it may be just a technical issue. In the interim, since we're not making a decision, Mr. Levin, Mr. Cox, I appreciate and the rest of your staff for making the comments thus far. I think it helps the commission get a better understanding of some of the issues of maybe where you're going. Obviously, there was significant concern on where you were, and obviously that's the driver for where we're at today. So. I don't believe I have Doc. Go ahead.
I was just going to jump in because I know we don't have the ability really to make any motions or action items. But before we conclude and go to public comment, I am feeling sort of compelled to summarize my thoughts, knowing that they'll carry forward probably into a future meeting. And I appreciate all the effort that's gone into the explanation and the planning and what hopefully will be coming soon to the Never Give Up program that will facilitate overall program improvement. But I just want to be really clear. I think part of the messaging that I heard here today is that we have to keep kids in state receiving services at all costs. And even if the cost of that is providing them with incompetent mental health care in state, and that's not okay. So I want to make sure that we're really clear about the fact that we need to be providing state-of-the-art services to Nevada children in Nevada, that accepting programs that provide substandard or subpar care doesn't make not sending them out of state any better. And so I really just want to focus in on that piece of it, that we all want quality care for kids in Nevada, but the two have to go hand in hand simultaneously. I also heard a lot about the fact that this program has struggled, like any program in Nevada, to provide competent, qualified mental health professionals. And we get that. We face it every single day. Growing that program simultaneously seems like an incongruent strategy to me. So I think that needs to be further addressed by HCQC. If you can't staff the program as it is today with qualified mental health professionals, adjusting your bed count or your license count higher than what it currently was doesn't seem to make sense in terms of the challenges and the struggle. This program's been in existence long before the COVID pandemic, and as Commissioner Cooper said, has struggled publicly and privately. So I am comforted by what I hear about what's changed in the last couple of months. I am comforted about what I hear about the desire to partner and to really engage in a system of care and to make program improvements. But really what I want to see is that we have an ability to incorporate and implement sound strategies for that program improvement that cover the deficiencies that have been identified. So that's my summary of my 2 cents.
Thank you. Ms. Martin?
Yes, good morning. I did see in the chat that Dr. Giron did have to step away from the meeting. He did have to leave. It was not a technical issue.
All right. Okay. Well, in that case, since we can't make a final, unless there's any concern, I do have one other question for Mr. Cox before we move on. We won't make any final decision on this on agenda item number 5 at this time, but I think we can tie up some of our loose ends since we have folks still here, and then we'll move into public comment. I don't see anything. I'm going to vacate items number 6 and 7 on the agenda. There's, I think, where we're at, we can't make a decision anyway, so we're not going to. But I guess the question I have for Mr. Cox is, one of the other questions that we had was, we had a certain number of clients where we had repeated events without a change in their treatment plan, and kind of as I questioned about the length of stay and holds, if we do the same thing over and over and expect different results, that's the definition of insanity, right? So I guess the question will be, with those, what have you identified as the driver to that issue as well? And then independent of the new model, like what have we done to address that since that time frame?
Thank you, Chair. Daniel Cox for the record. Some of the main areas that we've worked on is just working through transparency of the incidences amongst the treatment team, making sure that the treatment team is exposed to those incidences at a faster pace, so that they're able to review and make those modifications to the treatment plan, depending on the trending of a particular client. Weekly, they're assessing physical interventions and making sure that they're tracking the clients that are involved in those particular physical interventions, so that the treatment team can then be able to review those particular clients and make adjustments as well. We've introduced a handful of professionals that have collectively, 35 years and 40 years and 25 years and 20 years of residential treatment experience. And so we brought in an additional set of individuals to support the review of the increase of audit cycles that we're doing to make sure that the treatment plans are being adjusted at a more appropriate pace and to address the needs of the client as they are sending that trend to the treatment team. So mainly it's just an increase of programming oversight. So.
And this is for the record, thank you. I would also add, with the introduction of the red flag meeting process that has facilitated our ability to respond very, very quickly once we identify a maladaptive behavior or a youth who is in emotional dysregulation or in crisis for a period of time. We now have a methodology to quickly conference that child and adjust the treatment plan accordingly based on our understanding of why that child's going through a tough patch.
All right, thank you. Commissioners, any other comments before we move on? I think if we need to, we can have a discussion at a later commission meeting in a closed session to bring things forward to the open session, and then we can move forward. So I will, because we don't have quorum, I will be closing this out as just a closed item for this time. We won't make any determination at this point. And then we'll move on to public comment. Again, no action can be taken upon any matter raised during a period devoted to public comment to the general public until the matter itself has been specifically included on an agenda as an item upon which action may be taken. As a reminder, all public comments are limited to 2 minutes. And before we open this up for final public comment this afternoon, I just want to remind everyone that if there are issues or concerns raised that are more specific to a regulatory or law enforcement capacity, I ask that those issues be brought forward to them. The commission is not a regulatory or enforcement body per statute for certain aspects. I just want to make that comment because there was some comments made in the early session that were of concern, and I just, after consultation, just want to make sure that we have that listed. All right. Do we have anybody with public comment at this time? I see Miss McCullough. McCullough?
Yes, sir.
Yes, ma'am. You have 2 minutes.
Yes, sir. So it's cool that NGU is over here making these changes now, but NGU still needs to be accountable for the damage that's already there. Multiple staff and the children. I just have a few, sorry, I took some notes as they were talking. Mr. Levin, I will be reaching out to you. I did take your email just to speak to you on the things that have happened. They speak about a 40% decrease in restraints at NGU, or is it that they're not reporting it? Because they do alter statements of facts and remediations, and that's factual. Recently, they've been staff that they're actually combining classes, so they have about 1 staff to 9 to 12 students. Youth mentors are not really allowed to mentor. We're really glorified babysitters. To be honest, hearing them speak kind of made me feel sick. Like even now, my heart is just beating so fast, just the lies. They don't really know what's going on that facility until you're actually there. I've never even met, I've never met Matt Daniel or
I'm going to just pause right quick. I'm not going to take away your time, but if anybody has their mic open, please close it so we can be respectful of each public comment that's being made. There's some background in the chat right now. Thank you. Ma'am, you can continue your time.
So I do not even know who those people are. I was never introduced to the sanctuary model that was implemented after I left. Calm every storm, I don't think is the issue. It's the lack of training that is the issue, because the new holds actually hurt more. I've actually been put into it. And NGO hires anyone. Right now, there's a staff member that is actually on suspension because of her background, and this is months after she's already worked. There was a staff member recently let go for her background, but she was already working. So clearly there's a disconnect there, and they're just hiring anybody. I love that NGU would love to paint themselves as a desert oasis with picturesque views where your child can heal in the least restrictive environment and be given the tools to confidently go back into society and into their family successfully. But that would speak volumes of their lack of integrity, and it would be an outright lie. They speak of having no fear of retaliation. Well, I have been retaliated against, harassed, bullied, ostracized, with the final decision deeming me not a good fit after speaking against the abuse and neglect. I'm not advanced in mathematics, but none of that adds up. Words are just that. Actions will prove who NGU is and if they are truly going to make these changes, or if it's just for show. Because they gave the kids Crocs and had them a carnival once the state announced they were coming, so that the kids could be happy and things could appear to be on the up and up when it truly isn't. So it's cool that you guys want to make all these changes and that you're implementing them now, but are they for show, or are they for real? Because while you guys are playing around with all these ideas, there's actually kids that are suffering and that are being further traumatized by NGU, and leave the program worse than when they came. So you guys
We've
don't need
hit the
to know the table.
2-minute mark, ma'am.
Yes, sir.
I appreciate your comment.
Thank you, sir.
Chair, you're muted still.
Okay, thank you. Carrisa, you're showing up next.
Thank you. So I'd just like to take the opportunity to further clarify NDOC's role. We are a federally mandated, state-designated private nonprofit organization that's part of a national network created by federal law to give voice to people with disabilities who reside in facilities. Our monitoring team has completed investigations training from LRA, a nationally respected provider, and we take our role as a protection and advocacy agency very seriously. Our interest is in ensuring the legal rights, safety, and access to treatment for kids. We appreciate the conversation today about improving the model of care at NGU. The problem is that we're talking about what will be done when there are kids who are there now, who are unsafe, who are not receiving the treatment they need. There's a significant discrepancy between what has been said at the meeting today and what our monitoring team has observed on the ground, and not just historically, but during our most recent visits. Just around 2 weeks ago, I observed a child in the former observation unit, now called the sanctuary, but still a windowless room with carpeted walls. The child said she'd been in seclusion for 48 hours, only leaving to go to the dorms at night, and all because she had broken a rule. I've observed a youth subject to chemical restraint, dazed, unable to follow a conversation. I saw a child clearly in distress who tearfully told a staff member that she wanted to kill herself, and I watched the staff tell her that she was busy and turn the child away. I've talked to youth, to parents who don't know what a treatment plan is, staff who have never heard of the sanctuary model, and troublingly, there's no one that these kids can call for help. Despite our repeated requests, NGU has not allowed these kids access to a private phone so that they can call us as is required by law. Social calls to parents are limited to 10 minutes, and staff disconnect the call if the youth talks about something controversial. I think that there should be conversations about how we can improve behavioral health for kids in Nevada. Of course, there should be collaboration between advocates, providers, state agencies, but we can't talk about 6 months for fixing problems at a facility while kids are still there and still at risk. I want to restate my offer to provide a monitoring report to the commission, and I'll put my email in the chat box. We appreciate your work, and please do what you can to protect these kids. Thank you.
Thank you, Carrisa, for your public comment. Veronica and Felix, you are up next. Remember,
Hi.
2 minutes.
It's just Veronica. My husband had to step out, but what upsets me and what my comment is that I hear Daniel Cox talking about once a month walkthroughs through this facility. That is like an hour and a half away from Nevada, in the desert, where you have staff members who are not adequately or appropriately taking care of these children, who are our children, who are there because we trusted in your facility to give them the proper care. I mean, I hear stories from my son that I shouldn't be hearing. I'm not here just to advocate on his behalf, because he's no longer there, but there's other children there who are much younger than my son who need somebody to step in and help them. I've been one of the parents who have tried to communicate with this facility many times. We've been very hands-on with his treatment, and we still, my son was there for 2.5 years, and he still did not receive the proper treatment that he should have been given. He has PTSD now. He's suffered trauma. He's been in restraints. He's been hurt. He's been cut, and most of those times that those things have happened, we have not been notified. You guys talk about transparency with your staff. There's no transparency with parents. A change needs to be done to this facility. Once a month walkthrough is not enough for a facility that you run and you talk about quality of care. That is not enough. I am a supervisor myself. My staff gets supervised daily on their performance. This is not acceptable. This is not acceptable on the leaders of this program. Something needs to be done. This is not okay. My son has talked about sexual misconduct in this program. I know you said not to talk about anything illegal, and I'm not going to mention any names at this time because this is something that needs to be investigated further. There's lack of supervision, inappropriate things that are being shared with the children. This is not a safe place for children, and this is why my son is not there no more. He has come home worse than he has been, than he arrived.
Veronica, I understand your impassion. I want to be respectful of the time rules and be consistent across the board. As I mentioned, if there are things that need to be addressed in other forums, please seek remedies through those particular forums. Thank you. I see our next Brianne is the next person up for public comment.
The stuff I've seen done with other kids, not just myself, but I had seen other kids got punched, just pushed, the restraints, they cause bodily harm, like I have a broken toe from the restraints. Still it's broken to this day, and they left me in pain about like 3 months till they got me help, and I've been saying I was in pain. The other kids and the adults, I heard it's sexual misconduct, so it's like the staff are doing stuff to the kids, which I don't think they're doing a proper background check or whatever they do check out for the kids. I don't think they're doing the right thing. I've seen they blame the kids on the restraints for getting the bruises, but it's actually them. They're coming in with trauma. So if you put them in a certain restraint that puts them through that trauma or into a flashback, yeah, they're gonna get worse. And my actions has got worse while I was there. I have learned to do several things that I never done before, but yet I did them, and I don't think it's right. When I turned 18, they just kept me in this dorm for like 2 months straight, and it was basically like quarantine. They wouldn't let me be with anyone just because they were underage. I do not think that was right because of the lack of just meanness, because I just think that's cruel. I don't think that's right either.
Brianne, we've just stepped over the 2-minute mark. I appreciate your comment, but again, we need to be consistent with the 2 minutes that are allowed per person.
Yes, sir.
Thank you. Is there anyone else with public comment at this time? Seeing and hearing none at this time, I would like to thank NGU and the staff from EPIC for coming on today and sharing some information. I appreciate the public comments today as well. As we've said before, we want to make sure that we have a safe environment for all of our kiddos and the ability to collectively move forward and elevate our quality and continuum of care for the state of Nevada, especially for our kiddos. I do, again, appreciate everybody's time and encourage you to all work together to develop, improve, and advance our standing as providers, as a community, and look forward to continued conversation. At this time, we will adjourn the meeting, and I appreciate everybody's time today.
Thank you very much.
Yes, thank you.